All right, we're going to get started. Hi, everyone. I am Dory Chattel, Executive Director of the nonprofit Medical Education Institute, and we are delighted to be hosting today's World Kidney Day webinar with investigative journalist Carrie Arnold and Jen Ravert, who's a nurse, and Beth Witten, who is a social worker, and Rob is with us as well. They're all on the MEI staff or affiliates, associates, whatever we call you guys. And we are very pleased to have Dr. Keith Norris as a nephrologist as a guest. We hope that you enjoy the session, and I will turn this over to Carrie and she will get us started.
My name is Carrie, and I am an independent journalist living in Virginia. And I am a public health reporter. I focus on issues that are at the intersection of health and the environment. So, things, what is it about factors in this world that affect our health? And I've been investigating and working on doing stories about dialysis and kidney disease since 2019, when my mother-in-law was diagnosed with chronic kidney disease. And in 2020, I spent a lot of the year doing a large series of stories for the online magazine Undark, looking into financial issues related to dialysis organizations. And that was really successful and really eye-opening for me. And I continued working on dialysis intensively some more in 2022 as a National Journalism Fellow for the Center for Health Journalism at the University of Southern California. With their support, I have been spending the last year investigating a piece for Mother Jones magazine about involuntary discharge or termination or being kicked out of dialysis, basically. And if you joined us for the patient webinar earlier, one of the panelists, Lorene, was a friend of a friend, and that's kind of how I started investigating this after her brother was kicked out of dialysis. And so that kind of got me started down this rabbit hole. And I thought that given all the data that Medicare, the Centers for Medicare and Medicaid Services collects on dialysis and kidney disease, that it'd be pretty easy for me to find people have been involuntarily discharged. And that did not happen at all. I went round and round and round, and finally I filed a Freedom of Information Act request with the Department of Health and Human Services, and I requested statistical data on all of the involuntary discharges for a 10-year period from January of 2012 through December of 2021. And so really without this data, of course, scientists can't study the problem, journalists can't look into it, and so we can't tell who is most likely to be affected. Are these disproportionately happening in certain parts of the country? Is this clustering in certain dialysis clinics? Like if you have one patient being involuntarily discharged, are you more likely to have another one? Is this, that kind of thing that, a good statistician can really answer. But given that no one has this data and getting access to it is really hard, no one's really been able to look into. But because I filed a Freedom of Information Act request, I did get all of that data in a big, ginormous Excel spreadsheet. And so what my analysis and reporting showed was that involuntary discharges are definitely on the rise. In 2012, at the very beginning, there were 310 people who were kicked out of dialysis. And by 2021, that number had reached 655. And so dealing with that data was a big part of my project. But the other part is I have a secondary grant for what we call engagement reporting, which is sort of like centering the community that we're doing our reporting and writing about, and giving them a chance to share their thoughts on what topics and what aspects that they want me to cover, and giving them a voice and some control over what's being investigated. And so to begin with, I convened a number of focus groups with dialysis patients just to talk to them about issues that they're facing, what they want readers to know about being on dialysis, and what their concerns were related to involuntary discharge. And so that was kind of the beginning part. And the other part of engagement reporting is kind of circling back after you've done your story and kind of letting them know what you've learned, and, kind of providing resources and that sort of thing. And so that's what these webinars are, I've partnered with Dory and Jen at MEI to kind of do 2 sets of webinars, both of which are focusing on patient-provider communication, because one thing that came up again and again and again in all of the hundreds of people I spoke to for this story was that a lot of the involuntary discharge kind of traced back ultimately to a breakdown in patient-provider communication. Patients somehow weren't able to get their needs met in the dialysis clinics. They didn't know how to communicate with the clinical staff because no one teaches you. I mean, I have chronic health conditions and I had to learn from the ground up, exactly how to read my own medical notes and everything like that. And so, like, no one teaches you how to do this. You're sick, you're potentially dying. It's very emotional and it's very, very, very difficult. And sometimes you're in a bad mood. It can be very easy to end up with a label of a difficult or problematic patient, and it kind of, that reputation feeds on itself. And so then everything that happens every time you snap at somebody, which maybe might not be the best behavior, but is certainly nothing egregious, it kind of keeps building on itself as you get that reputation and it follows you. And so for patients, we put together a seminar on communicating better with your team and, what to do if you have concerns and that sort of thing. And so this one is for people in the dialysis clinics, because of course they don't necessarily receive training in de-escalating conflicts and dealing with cranky people, and it's really challenging. I've worked retail, it sucks, it's hard. And so, I think there's also part of the problem is people just don't know how to deal with some of these situations when you're overworked, underpaid, and overstressed. And so this is really meant to be a chance to kind of help professionals learn to think about some of these issues maybe a little bit differently and go a bit deeper with the behaviors they might see, and kind of understand what might seem completely off the wall to them actually makes a lot of sense to a patient who's very, very scared and has very little control in their own life. And so that's kind of what this webinar is going to be talking about. And we have Jen, who is a former dialysis nurse, and we have Beth, a former social worker, current social worker, but who's worked in dialysis clinics. And we also have with us Dr. Keith Norris, who has done work on involuntary discharge. He is one of the lucky few who has gotten access to this data as well. And so he just published one of the very few research studies on the topic. So I was going to give him a chance to talk a little bit about what his research is showing and kind of provide a perspective on, where this can lead if things keep going badly. So I'm going to open this up by handing the stage over to Jen and giving her a chance to talk about what she's learned in her years as a dialysis nurse and then at working at MAI.
Okay, well, I have a little bit of a reputation. Thank you, Harry. My reputation is I've always loved the difficult patients. I've found them to be the most rewarding. And I think my reason for that is because I like figuring out what is making people unhappy and how that can be relieved. Oftentimes I've found that it's been in the realm of home dialysis, that's been really a good way for patients who didn't jive with the clinic environment to feel comfortable somewhere and still get their treatment. One of the things that I'm not sure people really understand is that when a person is being perceived as difficult, it's not necessarily the person. Obviously, there are people that have personality disorders or who have, or genuinely bad people. But most of the time, what you're seeing is an emotional response from probably a perfectly normal human being who's feeling a little bit like a trapped animal. And trapped animals tend to lash out with anxiety. And that's sort of the position that clinical care puts patients into. Human beings are not meant to be institutionalized, even though it's very efficient on the medical provider end of things. It really doesn't work well on the human end. And that usually leads people to feel completely helpless and very panicked. So some of the things that you can ask people very honestly is what's bothering you? It's an open-ended question. It's non-confrontational, and it gives people an in to hopefully start expressing themselves to you. If you notice that a patient is not themselves, that's also a really good way of getting in there. When you get to the point of conflict, a lot of times people are misunderstanding each other. And one of the best things, and I learned this through years and years and years of retail, is you can actively listen to a person. You can get to their level. You can use a calm, pleasant tone of voice. You can listen to all of what they have to say and not interrupt them, even if they're going to go on and on and on forever, because they might just need that release. And then after they've had that release, if you take what they said and repeat it back to them, am I understanding you correctly? You're upset about. Can you elaborate? Can you tell me more? What you're doing there is you're starting a conversation. You're not actually telling them they're wrong. You're not confronting them. You're not telling them how to behave. You're letting that emotion go. Once that happens, you're in a place where you can sort of repair whatever friction you have. What else is bothering you? And if you've upset someone accidentally, it's okay to own that and say, I'm sorry that I upset you. It's not necessarily, people rub each other the wrong way all the time. They do it in close families. They do it amongst friends. Of course, it's going to happen in a dialysis clinic where your patients are spending 20 hours a week in and out of your unit. Everyone's going to have emotions at times. A lot of times healthcare workers need to check our own attitudes about our patients. And I think it's really important that we recognize that a lot of the times the people that we take care of are pretty traumatized. They're not really feeling understood. They're not feeling heard. They're feeling rushed. They're not feeling like we're taking our time and fully assessing them. And all of these things cause them to ask questions. And if we get defensive over those questions, we're not really being good providers. We're not, engaging their questions. We're not answering them. We're not looking anything up to try to make them feel less panicked. So I guess the main thing I want to say tonight is that it's oftentimes not the person that's difficult. It's the situation that's difficult. And when people are asking you questions or if they're criticizing, sometimes you can instead of taking that personally, kind of depersonalize it for yourself without disconnecting from the patient. Realize it's not necessarily personal about you, and thank your patients when they find something that you can be doing better. A lot of times just shifting it, saying thank you for what you're doing right, thank you for reminding me to wash my hands, can be the difference between an unhappy person that can absolutely not be relieved and a patient who feels like you genuinely care about their well-being. That is what I have to say about that. Does anyone have feelings about having emotional outbursts yourself? Like, think if you've ever had one and how easy it is to lose that control when it spills over. I feel like patients do that on a regular basis and hold it in very well until they don't.
I mean, my cat at the vet has in big block letters on her chart that says grumpy when restrained. Because she is normally very sweet and very docile, but you get that rectal thermometer out and it's right. Like insta tiger. And so, you know, and I had a vet comment to me once, like, well, I see you adopted her for her looks and not her personality. And I'm like, okay, she's cute. She is adorable. Maybe she'll join us. She did last time, but this is not her usual personality. Like, right? She's scared. She's being poked and prodded. She has no idea what's going on. Like, no, this isn't her normal behavior. Please understand this.
Right. And so all the dialysis patients, they're going to be restrained for the next 3.5 to 4 hours usually, right? And so but I guess we need to probably add that to their chart, put that little label on top of everybody's chart. Grumpy when restrained.
You know, our patients, you know, have a lot of needs. There's social workers in our training, we learn about Maslow's hierarchy of needs. And so basic needs are our physiologic needs for food and shelter and clothing, and then we have safety needs. And patients in dialysis, people that work in dialysis, I don't think understand how much safety is important to patients and how they want to be protected from harm. And, you know, some of them have seen bad things happen in dialysis clinics. And years ago when I was working in dialysis, I told the patient care techs and the nurses, I said, you know, these patients come in here and they're afraid they're going to die. Some of them have seen patients die on dialysis, and they're afraid, you know, what's going to happen to me? Will these people take care of me? I don't think they like me. Will they kind of walk slowly to come over and help me? So they have those safety needs, and then they have psychological needs. And at the top of the triangle is self-actualization. And I don't know how many people actually make it that far, but it is great when they do. And our goal is to try to help self-actualize our patients. So, you know, there are times that patients come in and they don't come in on time, and they try to leave early, or they skip treatments. As a social worker, I would sit down with patients and I would talk to them about what was going on. You know, was there some reason why they were late? You know, we had cab drivers bringing people in, and sometimes they were not punctual, and, you know, the patients would get there late and the staff didn't know that. They just knew the patient was late. That screwed up everybody's schedule. Now we've got to either shorten somebody's treatment or make the next person be late. And then when patients would leave early, I have had patients that had to leave early because of work responsibilities or childcare or adult care responsibilities, or they were afraid their ride was going to go off and leave them. You know, some of them worry about retribution, not only from the clinic, but from the transportation providers. And so sitting down with the patient, and I realize today I have been out of the clinic a long time, and I know that today everything is fast paced and too few staff, and people don't have the time to sit down and talk to patients as much as it would probably be a good thing if you could. So, even when you're sitting down with the patient, if you're a nurse or a tech and you're doing their assessment, or you're doing their needle sticks, you're doing the cannulation, to find out how things are going for them. How do you feel like we're doing and taking care of you? Is there anything that we could do to make your life more comfortable? Sometimes people leave dialysis early because they're cramping, because they feel bad, and they think that's going to help them, when actually sometimes it makes things worse for them. Social workers are administering the KDQOL 36 survey. That can really give staff, the social worker and the rest of the team, who are all supposed to be working on a plan of care, that can help give you some ideas of things to work on to improve the patient's life. And maybe it will explain why they're skipping or shortening treatments. And patients may lash out at staff because they're afraid, because they're depressed, because they have post-traumatic stress. I don't think we deal enough with post-traumatic stress in a medical setting as much as it needs to be. Soldiers, when they go to war, they come home. They don't have people typically shooting at them. But our patients are in a situation where they could have something bad happen to them anytime they walk in that door. So, the other thing is we have different cultures and different racial and ethnic groups, and we don't always understand each other, and we don't know what triggers somebody else. So it's important that we try to learn about our patients. And if you sit down and talk to somebody that's different from you and say, tell me a little bit about your culture, I'd really like to learn a little bit more, then you can find out, and they will feel like they've got a connection with you. And like Jen said, because somebody asks a question, try not to take it personally. A lot of times they just need more information. They need to understand why you're asking them to do whatever you're asking them to do. It's just really important. And so far as involuntary discharge, the interpretive guidance actually has certain situations that they say you cannot discharge a patient for, and that's failure to follow facility policies, shortened or missed treatments, and failure to meet facility set goals for clinical outcomes. So, I know that there are times that patients get discharged for invalid reasons, and I don't know whether Dr. Norris is going to talk about that, but I know that does happen. I've seen some of those data, and I know that the ESRD networks have a report on patients that you're supposed to fill out when patients are out of the clinic for over 30 days. And I've had people social workers tell me, well, that's an administrative discharge. Guess what? That's not regulatory. It's a data thing, and so if a patient is gone for 30 days or 45 days or 560 days, like a patient I'm working with now, got discharged from their clinic, take them back. Take them back. If you've got room, if you don't have room, help them find a place, because that's the regulation says you're supposed to help people find another spot. So finally, I just want to say one thing that that I think is really important, and that is that patients have certain needs. We talked about the hierarchy of needs. So if you're working with the patient, think about how you would want to be treated. So ask what matters to them. Ask them how they feel. Be sure to listen to them, respect them, because they are the person that lives in that body that you're treating. Offer them choices instead of dictating to them. give them tools to help them do well, encourage them, and try to avoid nagging. Nobody likes nagging. I don't like to be nagged. And then please, 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 it's really important to show empathy. So think about what it would be like if that person sitting in the chair was your mom or your dad or your child, or your spouse. You know, how would you want them to be treated? And that's what I encourage you to do. It's not always easy when somebody is grumpy, but if you can do that, I think that will help you a whole lot.
Well, those are just, I don't know if there's anything else I need to say here. I think we've covered pretty much everything, but I'm gonna, one thing I'll say is the National Forum of ESRD Networks has decided that this involuntary discharge is something it needs to look into much more closely, right? As you heard from Carrie in the beginning, it's increasing, and a lot of it is probably, with the COVID pandemic, we see that this is, when patients are vulnerable and they have stress at home and then there are additional stresses, this is going to lead to more challenges. We've seen many more mental health problems occur over the last few years. And so when we're trying to work with our patients, we're balancing that. They already have a loss of control coming into the dialysis facility. As you heard, what we need to do, to the extent possible, we really need to make sure that we're listening, that we're compassionate, that we're understanding. At the same time, we have to make sure our staff is protected and safe, right? And so we do want to do that. And so it becomes challenging when some patients sort of go across that line where they can become abusive and disruptive, because we have to make sure all the other patients are safe too, right? But a lot of this, as you heard, probably can be addressed if we are more understanding of the likely problems that our patients have and are taking that little extra time to listen and to understand and try to work through the problems. So what we've decided to do is, so we heard about the number of involuntary discharges per year, and they've been increasing. There's several hundred every year, but there are actually 7 or 8 times the amount of intend to discharge, but it never ends up happening, right? And that's important, right? Because that means we've done a good job, not on everybody, but we've done a good job on a large number of people who are on the borderline for one reason or another, and there was a sense that they may have to be discharged from this facility to go to another facility or no facility. And, because of the staff at the facility, we're able to get many of those individuals back into the fold, back on the team, and to be able to go back to dialyze. And so that's really important. So we've decided we take a close look at creating some surveys to get a little more in-depth understanding of what's happening at a lot of facilities and for a lot of patients, to do some focus groups with nurses and patient care techs and social workers and patients and their family members, right? Because we want to find out more holistically what's going on. Look at whether or not it's helpful if we have some additional education, particularly around dealing with some of the cultural nuances that may arise, that can happen because of language, because of socioeconomics, because of race and ethnicity, because of gender. And so we want to make sure that it could be other identity, it could be religion or other identities. So we want to make sure that we give everybody the tools that they can do the best possible. And then think about what we need to do from there to put in place systems that will help to minimize this. But I think it's going to be tough as we go forward, just because we're seeing so much stress and mental health challenges, and dialysis patients are already some of the most vulnerable and fragile patients we have. And so as we see at a national level, more stress and mental health problems and individuals facing problems with stress and mental health, it's something that it's going to be important that we're proactive as a dialysis community to make sure that we understand at a patient and family level what's going on, that we make sure we give each facility all the tools possible, and maybe start thinking about what are new ways we need to think about how we address this. And maybe just the old way we've been doing it may have worked to a certain amount, but we might need new ways. And so that's why we have webinars like this, right? Because we have people who will come up with great ideas and suggestions and things that we might be able to test, right? And see how that works and how that might work. So
did you want to address health equity at all in your paper? Do you have some slides with you?
So health, I can do that.
I think that your paper is groundbreaking. I think that, very sadly, I'm not sure this community has really been looking through that frame, and it's an important frame.
Okay. Let's see if we can get that frame there. So when we think about health equity, a couple things that we looked at in our paper. One, I think most people here are pretty familiar with the disparities in how prevalent end-stage kidney disease is amongst different racial ethnic groups. And actually, what's not on this slide, the group that has the highest rate of kidney failure right now is now Native Hawaiian and Pacific Islanders. It's actually almost twice as high as Black and African American individuals in the United States. And I think that's because of diabetes. So although there's not as many numerically, the rates are extremely high, and it appears to be because of diabetes in those communities. So when we see these rates, what we would expect to find is that when we look at involuntary discharge, that it would be distributed equally to how prevalent people are in the dialysis facility. What we've actually found is that for younger African Americans, this is less than 45 and 45 to 65, about a third of the dialysis patients are African American, but here, about 45% of those ending up being involuntarily discharged are African American men or African American women, maybe even a little higher. At the older age groups, it's much more close to their representation on dialysis. So that doesn't appear to be much of an issue there. But for some reason, we're seeing much higher rates in younger African Americans. And how much of this is cultural differences and implicit biases, microaggressions? How much is due to socioeconomics and therefore additional stresses at home? Are things that we're not sure, right? Because we've never collected that data. And so we can speculate, but and it's not bad to speculate, but we don't want, but if we want to do the best we can do for our patients, we want to get the evidence, right? And so we really want to look into and find out why we see these differences that we see. And actually, this is just our first pass. So we now know we have to look much more closely into the entire issue, because this is a combination of intended to be discharged or involuntarily discharged. And so our next step would be to break it into the two groups and see what happens, what we find when we look at it at the two groups.
Well, and it would also be interesting to look at the reason why, what reason was given for the involuntary discharge.
Right. Absolutely. So while I said, we want to go beyond speculating and get to the evidence, since we don't have evidence, we did some speculating here. Right? Because we got to start thinking, but the speculation is important to start thinking about how we can start putting together the tools to gather the evidence. Right? And so thinking about what might be cultural gaps between patients and providers, which we heard about, and psychosocial and regional factors, which we heard about earlier. And might there be, structural racism within the kidney community, and might that vary from location to location? Are there programmatic factors that may not be, that may put disproportionate burden on selective groups of patients that may bring out those additional stresses and strains? Are there clinic-related factors? And then are there patient and caregiver factors, right? Because there are things that are happening at the patient's home. And many of the patients may have to be caregivers for other family members, or dealing with health challenges, mental health challenges, physical health challenges with others in their household, right? And we saw during the COVID pandemic that many minority communities tend to have more people living in a household, which was a reason for higher rates of COVID infection and complications. Well, that also means in that household, there are other things going on that could put additional stress and strain on the dialysis patient, right? And so all of those things those are, an initial pass of things that we thought about in saying, we really need to look into these more deeply and gather information about this, and then take that information and try to figure out what are tangible things we can do to make a difference. So I'll sort of stop there and bring it back to the group.
This is so important for us to think about. And I guess what really struck me about what you said was it sounded like young African-American men had the biggest challenges. And I just wondered if you had any speculation about why that might be.
Yeah. So it's interesting when we look at involuntary or intended, it's both men and women, but the situation gets resolved for the women, but not for the men. So it ends up leading to receive the discharges. And I think there's a variety of factors there. I think when I think about society and the stress of being a member of a marginalized and oppressed group.
Yep.
And then you think about, but yet you feel as if you're supposed to be a person that has this important role in the family and in the community, right? And so society has told you many ways that you couldn't do that and you can't do that. And now health is telling you can't do that.
Right.
So, and who you see 3 times a week to take it out on is the dialysis facility.
Yeah.
And so,
do you think, because it's a critical psychological need, according to self-determination theory, which is what we use to ground all our materials in, is autonomy, control. Right. And one of the first things to go when you get diagnosed with any kind of chronic disease is your feeling of control over your life. You feel like, an asteroid has struck your life and things are out of control. I just wonder, because we are, you might have picked up on this, pretty big supporters of home therapies at MEI, right?
Yeah.
And doing a home therapy is a way to regain control over your time, over your schedule, over your mode of treatment, over, how your energy level, all kinds of things. I know Jen feels this way, but we would love to see more challenging behavioral interactions, because I'm not going to label the patients, but we would love to see more of those interactions addressed in a way that returns control to the patients, because they need it, and they're taking it either in a non-productive direction.
Right.
They could be taking it in a productive direction.
I agree, absolutely. I think I'm also a big fan of home therapies. And as you said,
I knew we liked you.
And as you said, this is a way to give someone back a certain amount of autonomy that's been taken away from them. Well, and I think
yeah. Just a lot of those interactions, I think, are just power struggles. You need to comply and do this when I tell you to do this. No adult likes to be told what to do. The worst word you can use with an adult is should. We should never use the word should with adults. But people will take control for good or ill. Why not move it toward good?
Yeah.
And the sad thing is that sometimes the patients that are the difficult patients at home are the best. I mean, in a center are the best patients at home.
Right.
And unfortunately, a lot of times clinics will say, no, we're not going to let you go home because you've not complied in center.
Right. A great point. Great point.
Compliance is not the job of anybody with a chronic disease. We should lose that word entirely from our vocabularies. It is an acute illness word. It doesn't fit chronic disease. It never did. The job of patients is not to comply. It is to self-manage. And it's up to us to teach people how to self-manage productively. And if they're not, then that's on us. It's not on the patients. Yeah. They don't know coming in what it is they're supposed to do.
Yeah. And Beth, that's such an important point that you brought up, to think about, right? Here, we are denying an individual the opportunity to do something that's probably in their best interest because they haven't complied with doing something that they don't want to do.
Right.
It's like, I don't want to eat the asparagus, but I would eat the broccoli. No, you can't eat the broccoli until you eat the asparagus.
Yep.
So I do know that the ESRD networks do collect data on involuntary discharges and discharges that have been averted because of them working with the clinics and with the patients. And I can't remember what year it was. It was probably 2 or 3 years ago. They collected some data and they looked at the number of patients who were at risk of involuntary discharge that they had averted, and they calculated the savings that would have accrued or that did accrue to Medicare for not having those patients getting hospital dialysis, and it was $30 million.
Wow.
And that's in one of the annual reports, the summary annual reports. I think it was I can't remember what year. But anyway, that was pretty impressive to me.
Yeah.
And I'm working right now with 2 advocates that are working for a young patient in South Carolina who, through no fault of his own, ended up getting COVID. He has been in the hospital for over, the last time I heard was the first part of February, 560 days, because he's got a trach and he cannot find a dialysis clinic that would take him, or a nursing home that would take him where he could get dialysis.
Wow. And
think of how much, what I heard from one of the advocates was that was costing the state, because he's run out of Medicare Part A days. Oh, yeah. He's on Medicaid, costing the state $800,000 a year.
Wow. Yeah, and there are many other, not necessarily that far an outlier, but there are many other similar cases, as you mentioned, that are, leading to substantial costs to, our underfunded dialysis system, as well as, major stress and strain on those patients and their families.
Yeah. I wish if pie was in the sky and there was a pot of gold at the end of the rainbow.
Dory has it.
I would hope that there could be data collection that would show back in the day when they looked at what characteristics of clinics or patients or diseases that caused costs to be higher in dialysis clinics, and they adjusted for those things. I think they need to look at things like patients with trachs, patients with long-standing mental health diagnoses that dialysis clinics are taking care of. Because the advocate I talked with, she was like, I can understand why a clinic that's getting what it's getting under the bundled payment rate is unwilling to take some of these really challenging situations. They don't have the staff to do it. Now, if they got more money to take care of those patients, maybe they would be more open-minded.
Yeah.
We did get a question, and I wanted to wait till everybody was kind of done with their presentations, but it's a question that actually would have fit better in the earlier session, because it is, how does a patient request someone to act on their behalf when being dismissed from treatment? So I don't know if anybody here feels comfortable answering that question, or if we just tell this individual to watch for the recording of the earlier session, because that's the one that I think has the information you want. But in case somebody wants to comment on that.
Well, I know that in your earlier session, I did not listen to it, but I know that Arlene Mullen was on that.
Yep.
And she has been someone who has been an advocate for patients and has attorneys that work with her, and they've worked with patients to address some of the issues. So I think what you would have to do is to find somebody like Arlene, or talk to your social worker in your clinic. Hopefully your social worker is your advocate. Yeah. I always felt like I was the patient advocate, and I would basically tell the staff, I'm here representing the patient. I know you've got issues, but patients are afraid to speak up, and I have no problem speaking up. So, I would let them know that what the patient's issues were, and try to get across what the patient needed.
I just gave a link to Arlene's LinkedIn site, which is a good way to find her.
So, and she's not the only one. Like, I'm working with a disability rights organization in the state. That's who's one of the two advocates that this patient that I'm working on is from. And then the other one is an attorney who is not working as an attorney, but as an advocate. I mean, it's not like she's trying to sue the dialysis clinics or anything. She's trying to help the patient.
Well, and I wondered if any of the clinician folks who are watching this have either any questions or any sort of situations that they dealt with that were tricky that they wanted to share, or any solutions. Solutions would be great.
Or ideas.
Ideas, yep. And we'll just
whistle. That's not working. The Q&A maybe.
I'm sorry?
I said if the chat is not working, the Q&A.
Right. Yeah. I'm actually watching both.
Okay.
So I have both windows open.
Yeah, and while we're waiting, I would just echo what Beth said. I think, I would recommend going to your social worker first. They are amazing advocates, and I would say 9 out of 10 times they are able to, one way or another, navigate, negotiate, and come to a a resolution that works for all parties. And then from there, if you can't, then some of these other organizations and entities may be needed, but it's really, you definitely want to take advantage of your social worker. That is amazing resource.
That's a really, really good point. And of all of the staff in the clinic, it may be the social worker who is the most likely to ask you, what is going on that is leading to this? And how can we help? Versus just, you are being disruptive and we don't want to deal with it anymore, so you're out, which does not really help.
Yeah. And I think their training is such that they have a much greater understanding, I think, of all the social issues, the home issues, the clinical issues, and yet have that that sense of understanding, that usually that calm reserve, and the ability to make sure that patient is listened to, and get to
I'm sorry, I thought
and get to the
I didn't mean to interrupt.
No,
the follow-up question is, who do you go to when it's your social worker who thinks you're being difficult? that's yeah.
And
okay.
I would love to say every social worker is terrific. Just like I'd love to say every nurse is terrific, every doctor is terrific, every tech is great, every facility administrator is wonderful. And you know what? There are bad apples in all of them.
Right.
And if you're having an issue with your social worker, talk to the facility administrator or nurse manager. And then once your social worker has a supervisor, some of the large dialysis organizations have social work leads and, people up the chain of command. But the other thing, I hate to throw cold water on this, towards the end of this, but there was a survey that was done in 2017 of caseloads and salaries. Mm-hmm. And it really kind of tells you why sometimes social workers are not always available. Because of the caseloads that they have nowadays. Some of them have 150, 175 or more patients. In 2017, 68% said they didn't have time to do counseling, which is one of the mandated responsibilities. 62% didn't have time to do patient education. 36% said they were busy doing excessive clerical insurance and billing, and 70% of part-time and full-time, and 77% of full-time social workers said they didn't have time to provide psychosocial services to patients.
And wait, just remind us quickly, what was your caseload back when you felt too overwhelmed to continue working in the clinic?
So I had a caseload of 110 at 2 different dialysis clinics.
Yeah.
And I had to go between
175, y'all.
Yeah. I mean, there's no way. There is no way. I feel for the social workers. I'm on the social work listserv and I'm trying to help them, but I'd like to try to do what I can to help the people that are counting the beans to understand these beans count.
Now we had these bills to pass in California. They tried to pass them to get
more than once.
So the dialysis units are making all this money, and we want more. We this and this and this, and it was crazy. And for me, I'd say there should be a reduction in the social worker caseload. And then we should have community-based health workers that can go, to the homes and see what's going on and work with the patients there and stuff like that. And
there could be people that are, I don't know that I want to make it too close to social worker, case aid, right, that doesn't have a master's degree in social work, that helps with the transportation and helps with the insurance and some of that other stuff. So the social workers can focus on helping patients that are having a hard time coping, helping patients keep their jobs, helping them live full lives. That was what I really enjoyed doing when I was in the clinic.
So
Yeah.
Beth, you did get a "You are wonderful." I had to pass that on. All right. Well,
It's very sweet.
We are at the top of our hour. Oh, let me see. Nope. I think we have answered the questions that came up. We talked about all of the things. I think that we have used this hour pretty productively to,
Right.
cover a really important topic. So
I'm looking forward to seeing more research from you, Dr. Norris.
Absolutely.
I am excited to hear about it. This has been one of my hot button issues.
I'm inspired to move it forward.
I just wanted to thank all of you panelists and everybody who visited tonight and listened and provided questions and input. We appreciate all of you very much. Carrie,
Yes, thank you again.
Wrap us up? Okay.
Yeah. Look, hopefully my article will be published in Mother Jones magazine in May-June issue. It could be bumped because of global events over which I have no control. But nonetheless, keep an eye out for it.
My magic wand.
Yes. My cat has currently taken charge of mine, which is actually, it's a cat toy, so I suppose it's fair. So anyway, thank you again for joining us and for sharing, and for all the panelists for taking time out of your busy schedule to chat with us. I really appreciate it. Thank you.